and then in the cyberspace. So forgive me if that doesn't go very well. When we get to Q&A, bear in mind that because of that YouTubing bit, this session is effectively being recorded and preserved online for all eternity. So that will help with note taking for anybody who's so inclined. What other housekeeping do I have to do? Fire alarm. If there's a we don't have a fire alarm plan. If there's a fire, yes, the fire escape plan is the fire you escape out of that door at the back. There's no other way out, frankly. If you fire the back room, you're doomed. Have we got a hashtag yet? No. Make it back. If you really want, if nobody's being Twitter anymore, are they? Twitter's so over. Twitter's very last year anyway. If you are still tweeting, make up a hashtag for this event. So that's, I think, am I done? Somebody tell me if I've done it right. Thank you, my friend. Right, that's the housekeeping done. The fun bit of the conversation. This is a conversation under the heading, or the essence of a variety of research interests and long-standing topics of focus, one of which is public services and their improvement. And you may, depending how old you are, know the SNF as being part of what was once the Blairite vanguard of public service reform. We are now trying occasionally to return to that agenda and excite and infuse our political friends in the topic of making public services better and more efficient and more effective. So in that context, I'm delighted to be joined by our speakers today. I'm not going to introduce them because you've all read the bios and you know who they are. But in terms of running it order, I think we're going to go Richard Meddings first, then Norman Warner, and finally Charlotte Pickles. Then I'll ask a few impertinent and ill-informed questions of the panel before handing over to all of you for your much better questions. So the context of the context of the event, as you know, is the NHS is coming up to its 75th birthday. Incidentally, it's the chair of NHS England is approaching his first anniversary in the chair. Have I passed it?
A couple of weeks away.
Historic landmarks are beckoning in all levels. There's also going to be a general election coming up in the next, well, take your pick, 12 months, 18 months, where at a time when public concern about health and the NHS is, as usual, at or somewhere near the top of the agenda, and there's a general feeling that maybe the amount of resource we are devoting to health is not always delivering for us the health outputs that we need, and that there are some long-term challenges ahead in ensuring that our population is as healthy as it could be, given the amount of public resource we can devote to that health. So that's as big and broad an overview I need to give at the moment. We will get into some questions, particularly around the politics of what ought to happen next to ensure those outcomes are as good as they could and should be later in the session. But so running order, so we will reach and then Charlie will give you opening remarks, then some conversation, and then some questions. So with that.
James, thank you. Actually, James, thank you for hosting us today, and thanks to the Social Welfare Foundation for the invitation. I'm delighted to be here. It is our 75th anniversary, and 75th anniversary will be celebrated, deserves to be celebrated since the NHS Foundation. But equal and opposite with celebration of the 75th anniversary, will no doubt be a louder call out is the model still fit for purpose, and one can see that debate running strongly. Too often when I read commentary around the NHS, it tends to be an array of simplistic or singular solutions, as if actually we can reach for a sword and slice through the Gordian knot. But what I think we all recognise is that it is a multi-dimensional challenge. It's an ecosystem, it's a whole industry. It's not a dreadnought, it's more better described as a flotilla of essentially different and vested interests. So if you think that there are 220 acute trusts, 49 specialist hospitals, 240 community mental health hospitals, and each of those has their own boards. Their boards have fiduciary responsibilities. Separate to that, we've got 20 royal colleges, with over 6,500 primary care GP practices, all of which are private sector essentially, SMEs, 10 ambulance trusts. You begin to get a picture, actually, that this is an ecosystem and it's not one single entity, one single organisation. And clearly it's also boundaried. And we've organised it in such a way that we've boundaried it with healthcare, with social care. So the gap between health and social care is a pretty firm boundary. And one of the things I'll talk about in terms of integrated care systems is our attempt to go across that boundary and to try and make it more permeable. What's the fundamental challenge? I mean, put simply, it's exponential growth in demand into an undercapacitized system. And if we just talk a little bit about demand, the population of England, not the UK of England, this is NHS England I speak here, has grown by 7.5 million people in the last 20 years or so. That's a 15% growth rate. The population is aging. So actually in the last decade, since 2010, over 70s have grown by 30%, and over 70s with what are called comorbidities and multiple conditions have grown by over 60%. 28% of the population is defined is obese. And we clearly have hugely rising mental health issues in the population. And so we have 4.5 million people in NHS England currently receiving mental health support. And there was an over 30% increase in 2022 in children and young people presenting to the health service and getting support from the NHS. And of course, the other area of demand, because the NHS is not static. It's actually always changing, always evolving, and it's very different than it was 40 years ago, or certainly 75 years ago. It continuously evolves. So actually we find ever more illnesses and conditions that the human condition can suffer from, but we also find more treatments. And so actually that demand itself is also a significant part of growth. Undercapacitization, let's do the physical capacity point first. So relative to population size, we have a third the number of beds that Germany has, half the number of beds that France has. If you take scanners, MRI scanners, CT scanners, we have less than half the average for the OECD. So in physical physical estate and capacity, clearly there's a challenge. And in the workforce, we're 15% fewer doctors and 25% fewer nurses than the OECD average, again, relative to population scale. So you can see there's a capacity issue, and there's also a growing demand issue. What are we doing about it? This is an NHS England board perspective. We're clearly focused on immediate challenges. We get huge support from government, from the Department of Health, Secretary of State, from the Chancellor, from the Prime Minister, on urgent emergency care, on the winter plan. We're already planning for next winter now. Waiting lists. Clearly, there's very significant focus on driving down the waiting list to the best of our ability, and on primary care access, but also significantly upon productivity and efficiency to try and find and remove waste from the system and essentially to respend that. Longer term, and you're probably aware that we are merging essentially 5 entities at the top of NHS England. It's 24,000 roles, and we're looking to take up to 40% of the headcount out. Clearly, that has a cost benefit, almost £500 million a year of saving, but it's more about debureaucratization and decentralization. And actually, it's in tandem with the emergence of the integrated care systems. So we want to devolve more authority and autonomy to the integrated care systems. And one of the ways to enable that is essentially to remove the burden of head office, to debureaucratize the head office demand. So the integrated care systems, for me, are a really important evolution of the health service. And as they earn their autonomy, I think it's important that they earn their autonomy. Actually, then they will have more powers devolved to them. Workforce. We have done, I think, a truly excellent piece of work on the workforce, long-term workforce plan. It was asked for by the current Chancellor when he was chairing the Health Select Committee. It was then specifically asked for by the Secretary of State. And we have done a very good piece of work. It's not only NHS, we've consulted widely with colleges and with health think tanks. We've tested the analysis, and it's now with government. And coming into the health service from outside, we need a long-term workforce plan in what is a long-run industry ecosystem, and where training takes time. Technology, the federated data platform is a very significant step forward. It's an intermediate translation layer which will allow communication and effective data sharing from primary through secondary and amongst secondary systems. And we've just launched that procurement in the last couple of months. And the NHS app, I think, 32 million subscribers, adding to its functionality, make appointments, order prescriptions, consider, get your own health records, and actually also increase functionality and increase support to patients to help them self-manage conditions they might have. So I think that is going to potentially revolutionise the way the health service runs. And then cancer, significant. We must stay very focused on cancer, supporting life sciences, and then genomics. Genomics, we're already doing whole genome sequencing, and we are the world leader actually in applying genomics. We currently have genomics sequencing and testing for many newborns and young children who have very rare diseases, but actually we can now scan for over 3,000 rare diseases and 200 cancers in our genomics capability. And we do that, I think, because we're the National Health Service. But there is a very real need for a philosophical shift. And that philosophical shift is what you'll expect, which is more towards community and more towards primary, and also more towards prevention. And we need to do that. But the reason I started with capacity is actually, this is a multi-year challenge that we can't simply just strip capacity from an under-capacitized system and put it immediately into one other area of the service. We've got to do both. But philosophically, we must shift more into primary, more into community, and more into prevention. And then lastly, in my mind, two areas where we need real transformation reform. Primary care, we're coming to our 5th year of the contract. GPs do the most remarkable job. It's a vocation, they work hugely hard, they're under intense pressure, over 1 million GP appointments every single day in England. And but we need to think about how that model changes, particularly going to put more primacy on it. And then the second is capital. Capital underinvestment. We are significantly underinvested versus the OECD over the last few years. We've spent 2/3 of what the OECD has spent in capital in the last 8 to 9 years, and 1/3 of what Germany spent. So we need a much more programmatic approach to capital, and only in that way can we drive better productivity, actually through a system which otherwise is suffering real strains. I'll probably talk for too long, but there's my introductory remarks.
Awesome. Thank you. I've only taken down about 6 or 7 questions you're asking later on, so I can't remember how many people listening have got for you. But we're not going to do that now. So we can go through our opening remarks from panelists. And next speaker is one of whom, among his many other far greater accolades, is also an SMF author who helped us through our pages of our Pickles last summer on with a pamphlet on what ought to be done to secure a happier and better future for the NHS and the nation's health. So you may recap in some of that now, but Norman, your thoughts based on your considerable experience of doing these things.
Thank you, James. Well, I'm actually an author for both reform in the past and SMS, so I feel quite at home here.
And the NHS.
Okay. Yeah, well, I've said some rude things about it. I'm a bit of a blast from the past, and I want to talk a bit about the past. I don't disagree with anything Richard has said. And I think if I was chairing NHSE or I was a health minister now and I would have to behave myself, I would be saying, carry on doing what you're doing, Richard. That's about probably the best you can do in the circumstances which you are confronted with. And that's not meant in any patronizing way. The card's been dealt when Richard took over the NHSE, and there's a limit to how much he can do to change the way those cards have been dealt. And he's doing the things which he has some control over, which is perfectly sensible in the circumstances. I want to take a more forensic, longer-term look at the NHS. Everybody talks about Beveridge and what a wonderful man he was. Well, he was a wonderful man. One of the things he said when he wrote his 1942 report was what this country needed were 2 things in terms of health. It needed a preventative program and it needed a care and treatment program. The NHS has done a crackingly good job, by and large, over the years on the care and treatment, but it has not done a very good job on the prevention. And part of the problem was it was never set up to do prevention, because health prevention involves a whole load of interests outside the health and social care system. And so the villains in all this are a succession of governments who simply neglected public health. It's as simple as that. And they got worse as time has gone on, because they keep cutting the budgets of public health as well. So you've got a situation in which Richard and his merry men and women actually have no control over demand. There is no, the only control they've got is to ration. And so they are prisoners of this system and this failure to produce prevention and public health, which would enable them. Obesity is a crackingly good example. And Henry Dimbleby has resigned as the obesity czar in food, because governments simply do not address that issue. I'm not making a party political point, it's all of them. They're all to blame. And unless that changes, what you've got is NHS England having to ride the bicycle faster and faster and faster to try and cope with some of the consequences of that particular issue. I want to say a little bit about the present, and the reason why I'm not all that optimistic. The NHS has been dealt some pretty bad blows over the last 15 years. Let's just remind ourselves what's happened over the last 15 years. 2007 and 8 financial crash, austerity, George Osborne, 1% a year real terms increase for the NHS, going over about a decade now. Along comes Brexit, which takes away big chunks of the workforce in both the care and the healthcare sector. Then we have, I've forgotten, that wonderful Lansley reform, which stopped the NHS functioning for about 3 years. And this is the only, I've been around government a very long time. This is the only time I've seen a government in office have to pause one of their major pieces of legislation because they knew it was wrong. So you actually we spent 3 billion or so. We paralysed the NHS for 2 to 3 years, and that had big consequences for everybody in terms of productivity and performance. Along comes Brexit, as I said, takes away a bit of the workforce, and we rely quite a lot. We've never been self-sufficient in doctors. After Brexit, and we're just sort of breathing over after Brexit, along comes COVID. And now we've got a situation where the cumulative effect of these over time has made this system close to breaking point. There is, as Richard said, there is not one thing you can say, if I put that right, it would be okay. What you've had is a cumulative effect of unfortunate things happening to the NHS. And one of the most astonishing things about it during that period, we managed to go through that period when an organisation, a business, if you like, which is highly labour intensive, 2/3 of the budget by and large goes on pay and conditions of service. So that system has actually never had a workforce plan. So we managed to go through all this period without a workforce plan for the major cause of the expenditure in the system. Now, if you went and spoke to any private business and said, we know you've got this very labour-intensive system, what do you do about planning? And they will usually rattle off some things which they have done to make sure that their workforce can be recruited, can be retained, it can be trained to changing patterns of service. None of that has happened in the NHS. And the villain is not NHS England. The villain is the government of the day, and in particular, the Department of Health and Social Care. All the levers of workforce are in the Department of Health and Social Care. Pay, training, retention, incentives, pensions, that is all controlled with the help of the Treasury by the Department of Health and Social Care. So NHS England have never really been given the responsibility to actually decide what the NHS needs in terms of its manpower, woman power. So that's the context in which I'm going to stop in a minute. All I would lastly do, I want to say, do a little commercial for when things were better. They were better, believe it or not, between about 2003 and 2008. Most of that time with Blair as the Prime Minister, and I know that we can all boo Tony and Iraq gets people upset and all the rest of it, but he did win several elections, which was and by and large the public were very comfortable, 75+ % satisfaction with the NHS. And the things from that period, which I think need to be given more attention now, patient choice, which we all talk about, but which the NHS has never embraced. The patient choice is a driver of change. People will get on their bike and travel further for treatment. They will. We proved it with ISTCs. They would take the car up the motorway, and many of these new treatment centres were just opposite road. So they will travel. If it's a child, so they do have loyalty to their local hospital. But when push came to shove, if you wanted to get your hip replaced, you were prepared to get your wife or husband to drive you to the ITC, which was somewhere. And people did change until the consultant fouled up the tube and book system by not putting their sessions in the system. People were travelling distances to get treatment further afield. So patient choice, choose and book, independent sector treatment centres, contract with the private sector, boo everybody, and
not this building.
And increase capacity. What ISTCs did, not only did they stop elective surgery patients being bumped by the emergencies, they also increased the capacity and they increased the diagnostic capacity. And if you had a tough commercial director, as I had, you could make them do this at NHS prices. So anyone who said it can't be done, we did it. The LSE proved we did it, and we proved it worked. So you can go down that path. The other thing you've got to do, you have got, and Richard is right here, you have got to push things down. Try command and control, which the civil service loves. And I've been a senior civil servant, so I can say that confidently. Command and control doesn't work. It simply doesn't work because you stop people locally having skin in the game. That's all you do. So the issue of whether you can go straight to ICSs, that the jury's out on that, we'll see if it works. I would certainly say you can't actually do devolution without having something at a regional tier of some kind. And you've got to get that local people feeling that they've been fairly treated with the resource allocation, but they are going to take the rap if it keeps going wrong. And the more you can introduce a democratic element into that, the better it will be, because British like throwing people out of office, and they're quite good at it. So those are my thoughts, just to stimulate the discussion.
Thank you very much, Nora. On behalf of the Department of Health and Social Care, we can actually see them out the window over there, so we can pop around later on and blame them for all the ills. Just so before I go hand over to Shano, you put Richard on notice and say you, because Norman has raised obesity, and you made
looking at me.
You made a clicking noise. You talked about this, and you mentioned Henry didn't forgive me. I will be asking you later on if you agree with Henry gentlemen. Just to prepare your answer now on behalf of the press officer. Our next speaker, Charlie Pickles of Reform. Reform also occupy this building. To explain why this is a nest of centrist reformers. Another charitable think tank interested in the better management of public sector, public services, who is doing a lot of thinking on the future of the NHS and the future of health. So
we are, and I'm going to do a confession. I'm going to agree with an awful lot of what Warner said, because he's sitting in we've got a program for reimagining health, and we have a sort of steering council we've set up, and Lord Mayor is a member of that. So a lot that obviously I agree with on that. The sort of exam question is past, present, future, and I think in a sort of sentence summary, I would say in the past the NHS was absolutely visionary and world leading in its model. At present, it's nowhere close to being world leading. If you look at almost any metric, the NHS is underperforming against most comparable countries, and whether that's on, you know, health outcomes in terms of breast cancer survival, infant mortality, avoidable mortality, we are not performing particularly well. But we've never spent as much as we do today. And if you also look at our population outcomes, health population outcomes, we'll talk about obesity, but they are not good, as everybody in this room will know. So at present, I mean, it's hard, you know, I would say exactly the same as Lord Warner, that I perhaps he didn't quite say this, but I wouldn't envy being in Richard's position and the challenges and the pressures that the NHS is currently facing. And I think, you know, there's lots there that, again, I completely agree with Richard on, you know, there is a capacity question. I think it's not as clear cut as is often said. And I think sometimes we hear a bit of cherry picking in terms of the countries that we might compare to, but nonetheless, particularly on the occupancy rate, the NHS one is incredibly hot, and that does create problems. Therefore, when you have, you know, an emergency or you know, a kind of uptick, or like we have at the moment, still quite a high proportion of COVID patients that need treating. I think on the staffing question, I mean, I am aware of some of the stuff that's going to be coming out in the workforce plan, and I absolutely won't break any confidences, but I think there is some really good stuff in there. And I think that's very promising. I think that one thing I would say is it needs to be built upon the model we want to see in the future, rather than just continuing with trends today, because we should recognise we have 35% more doctors today than we did in 2010. We have more nurses. What we don't have is more people working in the community, and we also know that GPs have effectively sort of stayed stable, which is, as we've talked about, where some of the greatest pressure is. But we do need more investment. Again, others have said it, so I won't go into detail, but in the sort of capital end of investment. So the equipment, you know, we could be much more ambitious around things like modular bed capacity, around day case units, that kind of stuff, which could alleviate some of those pressures really effectively. And the government is doing some of that, but perhaps not as ambitious as it could be. One area we haven't touched on is the fact that there is vast variation in performance across the NHS. And actually, we should be asking ourselves why on earth there are trusts that are performing significantly better on similar budgets than other trusts that aren't. And one of the things that reform we've looked at, James mentioned efficiency, and several people have mentioned productivity, but actually the NHS is undermanaged. And that's not a popular thing to say. And I certainly wouldn't say that about HQ, but actually in terms of operational management, it is undermanaged, and we should have that conversation. And that's partly why we have such a high degree of variation. So, for example, we published it very briefly. We published a paper looking at what was going on in A&E, and we're all familiar with the wait time. So I think we're slightly improved on the last data, but it's still some of the worst wait times we've had. There are double the number of emergency medicine doctors in A&E than there were in 2010. Demand has only increased by about 20%, and yet wait times are on the floor. And that is largely because we're not getting patients through hospitals. And actually, yes, part of that is about social care, but a very large part of it is about NHS. And it's about management of the patients. It's about NHS provision, sort of step down care, rehab, that kind of stuff at the other end. And so it's not just about social care. So right now, we should be doing an awful lot more to be focusing on that. And then I think there is more we could be doing in the present around health inequality, how we actually ensure that those in the communities can access care in a timely way. They normally have poorer access both to elective and to GP, so primary care provision. There are examples in Brazil, which lots of people talk about. They have a model that uses community health workers, which are residents taken from local communities who then do a lot of engagement in the communities, try and identify unmet need, or try and sort of educate around support, you know, look at things like vaccines, etc. They're trying it in Westminster here, but it's not something on the whole the NHS is very good at, thinking about these more kind of community focused, seeing communities as assets, and trying to tackle health inequalities in that way. And self-management, we're really at the kind of, you know, very tip of trying to enable patients to do much more self-care. You know, we tend to focus on tech at the whizzy end, which is great, but actually, you know, the real prize is in enabling patients themselves to self-care, in understanding and monitoring home hospitalizations. We use a lot of that in other countries that have better outcomes, like Israel. And we're not doing enough. We are doing some again, and NHS England is doing some again, but not enough. So yes, there are big challenges. I think we're doing some good things at the moment, but at present there's still an awful lot more that could be done. But I think the really big question, as everybody has indicated, is about the future. And we know what the future needs to look like, right? Because we've been saying it for decades. So it was back in 2006, I think, when Patricia Hewitt published was it a white paper, I think it was?
What?
It was a white paper, thank you, Norman, which said that year on year, there would be more money going to social and community care than there would be going to secondary care or hospitals. Do you know if that happened? No. We then had a 5-year forward view. People remember that? It explicitly stated we would have more money as a high proportion going to primary and community care than we would do acute. Didn't happen. In fact, in all bar one of the years that was published back in 2014, 15, I want to say, the proportion of money in the NHS going to hospitals has increased compared to community and primary care. And we have a long-term plan, which is brilliant. And you could not find anyone who would disagree with what the long-term plan has as a vision. And we are nowhere close, as per my example there, about where the funding goes. And the ICS model, okay, if we get some great leaders who are going to be ambitious about shifting that funding, we might see some good results. But the model itself isn't going to deliver that, because the model itself is still largely controlled by the acute end of the system. So as Norman alluded to in talking about how we put things down to a lower level, how we actually get some type of local democratic accountability into the NHS, how we think about making that profound shift, which we failed to do despite very real ambitions to do so over the last few decades, we have to break the power of the acutes, and we have to actually take money out of the hospitals. Now, I totally agree with Richard that you can't do that in the short term. We have 7.2 million people on wait lists. We have to get through that elective care burden. We have people literally dying or getting more disabled as a result of their inability to access healthcare in this country, which comes back to the rationing point we've heard. But actually, we are going to need to be much more radical about how we break that model to achieve what the NHS itself says it wants to. And just very, very briefly, there's going to be lots of things that people talk about why it's so difficult, right? How do you close hospitals? How do you, do kind of double running of systems, et cetera, et cetera. I'm still going to want to come on to that. But I do think, and this may sound a bit cliched, we launched our Reimagining Health programme with a letter to the Times from 10 former health and care ministers, all saying we needed a much more honest conversation with the public about what healthcare in this country should look like, the balance between health and healthcare, because let's never think that healthcare is the same thing as health. It's not. And yet all of our resources keep getting poured into the healthcare end and not into the health creation end. In fact, that gets cut in order to prop up the NHS funding. And we need to accept the limits of what our healthcare can deliver. We need to talk about public expectations of what it can. We need to stop thinking that there's a pill or there's a medical intervention for every ill, because that's how we drive, partly how we drive more demand into the system, because we tell people to go there because they can solve the problems. And yes, we do need to think about the amazing stuff that genomics and innovation can do in healthcare. I mean, it's mind-blowing what it will be able to do around personalization and around prevention. But we've also got to stop over-medicalizing and over-drugging all of our population, because that's also one of the big drivers of cost. One of the big drivers of deaths in the healthcare system, because we prescribe too many drugs or drugs that don't work properly. So we actually need to have that honest conversation about what can healthcare do, how much are we willing to put into it? Because yes, you're right. In the Blair years, it was great. And you know what? We spent 3 times, the increase in the health budget was 3 times the GDP growth rate. Yeah. That is not sustainable. It is not sustainable in any world. So we have to have a conversation about how we change the model in order for it to become sustainable and to deliver better health outcomes at the same time.
Thank you. Not you. Thank you, Shine. Not at all. I'm trying to set up to my first question. In fact, it's going to be my only question, because we have it's coming in from our online friends. I'm sure people in the room want to have questions as well. The question that I want to put to all of you, if I can synthesize what you've all said in parts, I think, and I'm going to say from Richard's perspective, but what Richard said and the long-term plan. if it is agreed that we need to address and reduce the flow of patients into the system to reduce that rise in demand, which means a transfer of resource, and your phrase, Richard, the philosophical shift towards community and primary away from acute, and yes, Norman and Charlie have been a little bit more explicit about what that means in terms of in the long term, having fewer hospitals. And we've heard a little bit about the political challenge of reducing the focus on the acute sector, transfer resource to primary and community. Just some thoughts from all of you. First of all, on how would you go about making that political case? How to make that palatable and saleable and attractive to the public? It's weird, Charlie. You'll know that the Charlie's letter at the time was signed by former health ministers. It's always former politicians.
Do you know, didn't ask current ones, but I don't think they would have signed it.
So it's always easier to say these things. Sorry, no, it's always easier to say things as a former minister than as a serving one. So how do we get serving politicians of all parties to say the unpalatable things that we're all saying from this platform today? And for a bonus mark for anybody who can then explain to me how you reconcile this desire to do the politically unpalatable and difficult thing with greater devolution. How do you simultaneously empower a set of local politicians to drive through decisions that may well mean, and I think it was Norman who used the all important phrase, local hospitals. Now, we all know the phrase local hospitals is key to all good election leaflets. How do you get local politicians to tell local voters that maybe they might not have quite as many local hospitals in the future? So that's the very long and roundabout topic for discussion. Who will go first? Norman, first of all, how to make the study politically powerful?
Well, let's just go back to the 2006 white paper. Your health, your care, your say. Underpinning that was the most enormous public consultation and a vote by 1,000 people in Birmingham, where ministers gave up a Saturday to participate in this without influencing them. The public in that massive consultation, in their 10 top priorities, actually in their 20 top priorities, there is no mention of acute hospitals. Everything in there, what the public wanted, was all to do with stuff closer to home. So the idea, and it came as a shock to the ministers, second in the popularity was mental health. Now, nobody in government was talking about mental health as a priority area. So I think we underestimate where the public may be on this. And it's usually activists, often fueled by the consultants in the local hospital, who start the noise on changes to the local hospital. How do you do it? Read my pamphlet. Read my SMF pamphlet. That's right.
It's not reform.
All I've done is I've pitched an idea from Aradati, and the idea was polyclinics.
Yeah.
And you start investing. You just simply do what Richard says. You just stop the capital program going all the way to the acute hospitals. You start refurbishing the primary care sector with better buildings, with more diagnostics and so forth. That's what you do. And you don't listen to the permanent secretary, who actually was the main architect of stopping the money in 2006 and going down the path outside hospitals. It wasn't the ministers, it wasn't the public, it was the civil service who actually rejected and stopped the proposals that Patricia and I wanted to do, which was to transfer money in the budget outside acute hospitals.
Have more faith in the electorate to be more enlightened than you think.
That's right.
Love it. Richard, now can I remind you, I'm sure you're pretty aware that the other things you said, I know Deborah Kepi, you also talked about the reform of primary care. So I wonder if you could just expand on that a little bit in context of your response to the points no one's just made.
Yes, it's on primary care reform. I think again, I start by just absolutely asserting, I think, what a brilliant job actually primary care does. So I hadn't realised coming through, or as I approached this role before I took it on, over 93% of the population again with health is in primary care. The budget of NHS England is about 152, 153 billion. Depending what we include, we spend between 9 and 13 billion in primary. Yet 9% of the population's needs are there, and I think GPs and other health staff and people working in primary care in the surgeries and the practices, not just GPs, do frankly an amazing job. As I say, almost 1.1 million GP appointments every single day. Almost 50% are on the day of the phone call to ask for that appointment, and 2/3 of these appointments, almost 70%, are face to face. So think about that, and that's in a population of 57 million, and yet over 1 million people a day are going to see their primary care practitioner. On the reform, which is what you asked, all I'm really saying is we're coming to our 5th year of the contract. We need to think hard about how we can certainly improve access, and that can be partly through technology, but also I think we need to think about how primary care interacts. There's a very, very good report by Claire Fuller, the Fuller report, which sets up a multidisciplinary picture of primary care. I think it's well worth reading. I think it's excellent. But as we think about how it changes, I think we should travel with the dynamics that are already evident in primary care. We've got more of the practitioners actually say they don't want to be full-time practitioners. We've got more aggregation of practitioners coming together. Very sensible from my business perspective, because you can share back office, administrative purposes, technology, and do all that sort of admin on a centralized basis outside the front line, and then multiple skills going into primary care practices. So that's what I mean. On the pure hospital, I just disagree. And it isn't, though, that I disagree that we shift to primary. This thing actually sitting and managing practically in NHS England, I think such is the condition that we have running at 93–94% capacity or occupancy in the summer. OECD occupancy pre-pandemic was 76%. The Royal College of Emergency Medicine would say 85% is a safe level at which to run at. The NHS, to quote Charlie, actually runs really hot. So we have fewer bed days because we get people out fast, unless the system backs up. And the system backs up when we can't get people through. And it's quite right, a lot of that is a challenge of NHS processes. We think 30 to 40% is actually down to NHS processes, actually not getting people out through fast enough. And then we hit the boundary with social care. The reason I don't think it's fewer hospitals is because I think that we need to invest in that capacity as well as at the same time shifting. Because we have an obligation to look after the population today, rather than wave a magic wand and say we're now going to shift like that, and we're going to shift all the monies over. So unless there's more monies to come that go in, I think we've got an obligation to manage both. So we've got to boost the capacity. I then don't disagree at all on Darcy's points about polyclinics. I think they would be a brilliant innovation, an area that we should continue to invest in. So I can see Norman not particularly happy, not agreeing with that. I'm not saying that we don't shift. I'm saying actually the condition of our current secondary offers in our acutes, we need to continue to maintain and ensure they're able to operate. That will take, I think, more capital investment. And
Can I suggest you build some nursing, step down care?
There are actually what's interesting about this. Well, now I agree with that. In beds, so in 1989 there were 299,000 beds. We're now 100,000 acute, 141,000 beds actually in total. So 100,000 acutes and 41,000 essentially in mental health and community settings. Why did that drop? It's too clear to say it was money and austerity, actually. It was also a decision made by the senior medical establishment, whoever they were 20, 25 years ago, that we were going to be very good at prevention, which goes to my point. If you don't get it right, so then you end up where we are today. So we're going to be good at prevention, so we don't need the beds. And you know what? We didn't do very well. I still drink alcohol. Look at me. I probably would be defined as hopefully not obese, but heavy in that way. So actually, we didn't prevent the population essentially continuing to need those conditions. And we took the beds down in nursing home beds. We did the same thing. And we removed the nursing home beds because we said, you know what, when we look at it, this medical establishment, we're not very good at rehabilitation. And what was the answer? We took the beds away. That's not the answer. The answer could have been to improve the rehabilitation, not to take the beds away. So I don't disagree on the capacity point. I'm going to stop in a moment. Last point, if I can, is how to shift. I think Lorna was absolutely right when he said you need a sort of a regional some interleaving there actually. So between the 42 ICSs, I think until we get there, until the great leaders appear and until actually you can safely devolve more autonomy to them, actually I think we do need regional layers. And it's sort of a model I have from the private sector experience where you can't just have a head office which is shrinking and then straight to 42. It becomes really difficult, particularly when the head office is dealing with multiple requests coming from the government and so on. So you need a span breaker, and that span breaker I think is regional layers. But they also need to be relatively small. We don't want huge bureaucracies sitting at region, but we do need span breakers to help go up and down in terms of data and performance management.
Thank you. Very quick.
Very quickly. On the beds, one of the other reasons why they've dropped is because we do far more as day cases now rather than people needing to be inpatients. And actually, that's progress. That's a good thing. And so we shouldn't just assume that it's exactly. But my answer to your how do you shift it to you give the local politicians the budget, because every time while they can sit there and go, I want to keep this and it's got no cost to me to keep fighting it, that because it's national government who pays for it, where's the incentive?
We are in investments that like talk about English NHS. When you quickly look at Scotland, for example, what you mean in the universe of what you mean, perhaps.
Well, but that's the role to Scotland, right? Not to an actual low level. No, exactly.
Okay. Sorry. Covering Scotland.
Totally agree.
Other questions from colleagues, your friends in the room? Sorry, I have a quick it's there and then Laura. So yes, then Laura. Well, yes.
Yeah, one of our issues at the moment with the NHS, and particularly the future, is doctor retention. So what would you suggest about doing that? Stopping doctors from leaving the NHS and doing it other professions than they just have now?
Quick thoughts on better retention of doctors.
Well, I think partly it's what we would hope to see from the workforce plan is actually more improvement. Actually, I think the pressure that the doctors work under, I think, is very significant. By the way, that's part for me as a very personal view. I actually think what would be wrong in imagining a population of, in this case, England, which is better health educated more broadly, actually. And the fact I'm struck by is that we have some of our brightest and best young people applying to be doctors. What's the percentage who get places at medical school? Last year was 15.6% of applicants for our places at medical school. And so then we rely upon international recruitment, which is fine. It's not a quality issue. But as a strategic supply chain issue, I think that's something to be reflecting on. So I do think those working conditions are important, and the working conditions partly, I think, come from the pressures they're under. At the more senior end, there is issues clearly have been issues clearly with pension, disincentive to stay and disincentive to work, and I think that we've seen some recent changes which should alleviate that.
Can I offer something?
No.
You can't actually expand the medical workforce very quickly. And the idea that you just put a large number of new medical schools in place and you've got no capacity in the NHS for the practical training, which has often been deviled, is the reason why it is a feeder system.
Yeah, it is.
You've got to actually have enough places for training placements to come out of the medical schools and
to do
complete the qualification.
Yeah.
What we have never done in this country is actually look at whether we need to actually take 7 years to train a doctor. France does it in 5 years, and we have never done it on any scale, physician assistants. If you go to America, you're likely to be seen by physician assistants much of the time. And there are good practices in this country, like Sam Everington in the Bow Group, where you put a very large number of other people who can actually support the GPs and deal with a lot of the clientele. So we just don't do primary care very well. It's as simple as that. And if we were more ambitious, instead of saying we've got to train ministers announcing how many new doctors they're going to produce in 15 years' time, if they knuckled down and actually dealt with some of these other issues, they'd be better.
Can I ask was the question? I answered the question specifically with regard to doctors, but I don't disagree with anything you just said. The full report is exactly about actually market skilling in primary care. If I wrench my knees and I go to the doctor, actually I'd far better see the physio than see the doctor. And so actually that's exactly what we are thinking about. And the workforce plan has lots of very good thoughts about skills mix change, productivity, technology changes, but skills mix changes and the levels, to your very point, Norman, to which we train.
You're bringing the point that it is possible, it should be possible to train a doctor in less than 7 years.
I'm not avoiding it.
I would agree.
I would have thought
I mean,
so.
again,
Or
yeah.
you go to position associates or whatever,
Yeah.
so you change the skills level. At the moment, we train to the full skills, and actually, given the way we work in the system, most of the doctors don't get to work to their full skill. So actually, there is a need, I think, to change that mix.
Yeah, I mean, I would just add, I mean, it's interesting we talked there about kind of non-doctor staff, and people always say, oh, we've got fewer doctors than the OECD average, but we have more doctors, like entire workforce, but we have one of the biggest health and care workforces in the OECD, if you include allied health professionals. So part of our problem is our obsession with doctors, actually, and how we keep quoting doctors as being the issue, despite the fact that we've seen a huge increase in doctors in hospitals. Actually, nurses is a far bigger question for us, nurses leaving, and that will cause far bigger problems, because actually, you know, recruiting doctors, as we just heard, we could recruit many more doctors, but nurses is a much tougher question. And I'm just going to take a cheap pot shot because I can, which is not anyone here, but you know, the idea that someone who has £1 million in their pension pot and can afford to put more than the median salary in a pension each year, and we think that the best way to do retention is to give them even more taxpayer benefits, I think is an interesting question and an interesting government choice as to where to spend £1 billion.
Stay for the second hour of this debate, Laura Donnelly, I think your hand up next.
Yeah, actually, with the workforce strategy, I was going to ask about, and actually it's got quite similar themes. But I want to ask, what short-term measures do you think we'll see in the workforce strategy for the crisis right now in terms of the numbers? And also, it's been long waiting for a long time. Just wondered if you could give us some clues of what's holding it up and what we might expect.
So I'm going to probably disappoint you, because I am going to still answer by saying, actually, we've done, I think, which is a very good workforce plan. I said earlier in my remarks that it's been consulted with colleges and with think tanks, and we've had it validated in terms of are the underlying assumptions sensible. It does look at productivity benefits, it does look at skills needs, it does look at the changing technology, and therefore can we practice medicine and health differently. It does think about changes to primary and, you know, going outside the acutes in terms of where those skills should be applied, and then in terms of where it is, it's with government.
In that bill go there.
But to say helpfully, you know, we're getting huge support from the sector state on it. You know, the Chancellor clearly was calling for it when he was in a previous guise, and I'm sure he's very focused on it. So, but it's with government.
Some people were convinced it was going to be the budget last week, but it wasn't. Is there something? Did something go wrong?
I've got no idea. Well, you might be sure it's. I'm not even sure it's just a relevant question to ask me.
Any thoughts on immediate action to be taken on our workforce?
No, no one's mentioned the Treasury. So the villain is always the Treasury. It always is. It always has been. It was in my time. And the Treasury have some very odd ideas about how you can actually create a market for doctors, and very odd ideas. I'm not making this up. I mean, I've sat through some very interesting meetings that somehow we should flood the market in the UK with more doctors from overseas, pay them less, and drive down the price of consultants in this country. People have actually said that. So you've got a situation in which there is no agreement often in government about how to take forward planning of a workforce for the NHS. That's a shocking thing to say, but the Treasury is an institution and it has institutional thinking.
I mean, what can you do in the short term? You can't magic people, right? So you have to think about how you use your people more effectively and more productively. And I think that is where some of the stuff around home hospitalisation, self-care, you know, using those allied professionals, having multidisciplinary teams. But it's those things you've got to do, because you can't suddenly have more qualified doctors and nurses in the system. But I think there are lots of ways you can do that.
Yeah.
I've got one question from online, which we'll get back to a second, but was at the back, and no, right, back to, right, I'm prioritising getting the room, so you go at the back first, and let's do all these three together, so you've got that back, then on there, and then three. Okay.
My question is largely Richard, but it's about the future of NHS England itself. One of the things that a lot of people have talked about is the fact that we need kind of like structural vehicles to be more of a regional level. I think around how NHS England operates in terms of doing more communities and doing more with people rather than two people. So I'm interested with that in mind. What do you think the future of NHS England looks like?
Future of NHS England, there?
Yeah, and I guess there's a lot of talk about, you know, strategic sort of reform and future thinking. And it now probably looks like at least some of the cash for the pay deal is going to have to come from NHS England's budget. And how does that fit into that longer term picture, and what things is NHS England going to have to stop doing now and find like another £1 billion to cover the latest pay deal?
Yeah, I want to encourage him to ask his Henry Dimbleby question, because we've been talking about,
He's not going with that.
because, you know, we're talking about spending vast sums of money doing X, Y, and Z, but actually if we were regulating some of these harm-causing products, tobacco, alcohol, like that, salt and sugar, then this is about turning the tap off that demand that is overwhelming the NHS.
So that was the future of NHS England, paying for pay deals, and is Henry Dimbleby right? Yeah, no, trying to also what Richard's criticism.
Well, I think, I mean, syntaxes have had a mixed effect actually over time, and they are quite slow to change behaviour over time. Well, they have. I mean, if you just look at smoking, massive increases of tax on cigarettes over the years, and still smoking has been an obstinate.
Not falling.
Falling, but very slowly. Very slowly. It's not going to say syntaxes. I'm all in favour of syntaxes.
So it's not the only thing either.
Let me pursue the argument a bit further. I'm going to try and give you
In 30 seconds off your.
The problem with prevention here is that elected politicians across the parties find it very difficult to actually deal with this issue. And my proposal, again in my pamphlet, is an Office of Public Health, which is actually at arm's length and actually takes a percentage of the NHS budget each year, and actually is clinically driven, epidemiologically driven about the policies that government ought to pursue to actually drive down demand on the healthcare system.
I'm going to try for a quick thought on the future of NHS England. Does it happen? And then I'm going to go to Richard. He's now going to be a very confident. Richard's going to know how to pocket, which is headed where does the money for pay rises come from?
I knew you would see me do that.
That's one of those questions where you were going to cut answer that question.
So NHS, we wrote a paper about 5-6 years ago saying we should scrap it. I don't think our position has changed since then. I suggest we find a new role for Richard personally, but otherwise, I'm not sure why we need so many layers with thousands of people now sitting in the centre, which might also be an answer to how you pay for some of the.
So I think on the future of NHS England, I do think it's essential, but I think it needs to be smaller and retain its expertise. So a small expert centre is important, and that's partly because what's the interface with government? And is the government going to interface with 7 or 8 different regions and or 42 integrated care systems? It's also correct that NHS England has about 130 priorities, which is ridiculous, isn't it? I mean, too many priorities with no priorities, except that over 100 of those priorities are in statute, regulation or legislation. And when you say which of those would you not have performance targets or management targets and programs to support, actually you're not going to do obesity. We'll come to the Henry Dimbleby question. We're not going to do obesity. Are we not going to do breast cancer, prostate cancer, bowel cancer, early learning issues, autism? Which of these do you not want as government to be able to say, actually, you know what, we do have targets for performance managers, there's targets for investing against such programs. So it's quite a necessary function, but it needs to be expert and small and not bureaucratic. And bureaucracies need to keep testing themselves that they are small and expert, and that's what we're attempting to do. And then within it, it encompasses what Norman talks about, which is the regions. So they count in NHS England, and they also need to be not bureaucratic, but as I said earlier, they're very necessary span breakers. On the NHS budget, we'll have to see. We're already committed to finding over 12 or 12.5 billion of savings over 3 years. Julian Kelly, the very good, very able finance director, was pretty clear in an earlier board meeting about how difficult that is to keep on finding savings at pace. So we'll have to see, I think, where that extra money comes from. And it's clearly it's a conversation ongoing with government. And on the obesity question, and so our role, I'm not ducking it, but our role is sort of to deal with the consequences of the human condition and the population. As a citizen, I absolutely agree with you. I look at the state of our general health. You look at obesity, and the UK, I think it's the second most obese nation behind Malta. I think that's right. Yeah. But what on earth is going on? And when we think what it does to, it triggers 13 cancers. Yeah. It causes diabetes 2, musculoskeletal issues, cardiovascular issues, and workforce challenges. It's outside, it's beyond my pay grade, but you would have thought, wouldn't you, that given that we would have, where Norman started actually on public health, more direction, whether it's funding or policy aimed at public health intervention and education, actually. And it happens so much more broadly than the health service. You would have thought, yes.
Any final, one last question there, and we'll wrap up.
Thank you. Thank you for your comments and your more view today. The American comments, you talk about the role of life sciences. I wonder if we could just ask you, so as part of the life sciences vision, and NHS England signed up the role of the NHS as innovation partner. And I wonder if you can speak to that a little bit, not just on the research side, but in the context of the changes that you spoke about, making use of workforce in different ways, technology in different ways. Where do you see the use of approved medicine being part of that?
So if there's a nice approved medicine, I think the NHS is under obligation to introduce that within 90 days of approval. In terms of how we engage with life sciences, I think again, I forget the number now of AHSNs that we run, but these are the structural units and the partnerships where life science innovation, be it pharmaceutical or medtech, can approach to see if they get innovation. I would say, and it's very personal, I'm not yet a year, there's a challenge because there's so much invention going on, and there's so many different voices saying, me, I can help, and often they can. The question is, how do you choose and how do you select? And so can we make, it's an open question, can we make less clunky the process of trialing, be it clinical trials, pharmaceutical trials, or medtech trials? I haven't got the answer to that, but I think it's a very good question that we should ask. But my predecessor was, he was this huge advocate for life sciences, and I agree with him. In terms of revolutionary change, actually, the more that we can absorb and enable that industry, and then use the benefit of their developments and skills, the better.
I was a life sciences pharmaceuticals minister for 2 years. And the key is not NHS England, the key on getting the balance right between what the NHS pays for drugs and protecting UK PLC with the life sciences industry rests in the department. And it is up to departmental ministers to hold that balance, because the job of Richard is to try and get the drugs as cheaply as possible. That's his job. You can't criticise him for it. So it's the minister in the department who has to hold the ring for this.
Thank you. We've got a couple minutes over time, for which I apologise. I'll wrap things up there. I also want to apologise to you all. Thank our online participants for joining online. Apologise to the ones who ask questions online. You can get them in, but there have to be some veg in the room as well as the biscuits. So forgive us for that. So with that, I will wrap up there. So thank you very much. Thank everyone in the audience, and thank you all to ask you all to give a hand of thanks to